Thank you all for coming back after our lunch break. We now turn to the second proposal scheduled for today, the Patient-Centered Oncology Payment Model. This proposal was submitted by the American Society of Clinical Oncology, known as ASCO. PTAC members around the room, in case anyone is just coming onto the afternoon session. As you do so, please read your statements on this proposal. Because this meeting is virtual, I will prompt you individually. So I'll go ahead and I'll start. Dr. Jeff Baylett, the CEO of Alteus. I have nothing to disclose. Next is Grace.
I'm Grace Terrell. I'm the CEO of Aventus Whole Health, and I have nothing to disclose.
Next is Paul.
Paul Crisal, cardiologist at New York Presbyterian, Weill Cornell, and Columbia. Nothing to disclose.
And Jay.
I'm Jay Feldstein, President and CEO of Philadelphia College of Osteopathic Medicine, and I have nothing to disclose.
Lauren.
Lauren Hardin, Senior Advisor for the National Center for Complex Health and Social Needs. I have nothing to disclose.
Josh.
Josh Lau, I'm an internist and medical director at the University of Washington, and I have nothing to disclose.
Kavita. Kavita may not be on. I'll go ahead and read her disclosure. Actually, let's see. I don't have her disclosure up. But let's see, because of her involvement in ASCO, she's recusing herself from review, deliberation, and voting on this proposal. So I think that should be sufficient for the purposes of today. Angelo?
Yeah, Angelo Sinopoli. I'm a pulmonary critical care physician and chief clinical officer of Prisma Health, and I have nothing to disclose.
Bruce?
Bruce Steinwald, I'm a health economist here in Washington, D.C. I have nothing to disclose.
And Jennifer.
Jennifer Weiler, I'm Chief Quality Officer at UC Health Denver Metro and a professor of medicine at the University of Colorado School of Medicine.
Great. Thank you all. I'm now going to turn things over to the lead of the preliminary review team for this proposal, who is Dr. Jennifer Weiler, to present the PRT's findings to the full PTAC. Welcome, Jen.
Thank you very much, and good afternoon to all of our participants. I'd like to start with a big thank you to my fellow PRT members, Dr. Paul Crisal. I would also like to thank Dr. Charles DeShazer, who was a member of our PRT during the entirety of the review, and his work is represented in our report that's presented to you. Because of personal reasons, Dr. DeShazer recently resigned from the PTAC, but as I mentioned, we included all of his work in our report and would like to thank him for that. We'd also like to start off by thanking staff and our contractors, specifically staff through ASPE and NORC. There was a tremendous amount of work that went into review of this proposal, given that it is in the domain of cancer care. And as we all know, there have been a number of payment models, and specifically alternative payment models and advanced alternative payment models, which have been considered over the last 5 years. Some have even been in development for a decade. And this committee has actually reviewed a number of different proposals. So thanks to the work of the groups to help us better understand this proposal in that context. We would also like to thank the Medicare Office of the Actuary also for their help in us understanding the impact of the proposed model, specifically with regards to the Medicare spending. And finally, and most importantly, we'd like to thank the Specialty Society for their what must be countless hours dedicated to this project. Also, the conference call and correspondence to our questions. We appreciate their engagement with us, helping us to make sure that we fully understood this model and its recommendations. Next slide. As with all PRT reports, we will go through the standard process of presentation. Next slide. And as a reminder, for those of you who weren't able to join us in the morning session, this is a summary of what our PRT composition is, roles, responsibilities, and process. This is available on the PTAC website, so I will not read through it at this time. Next slide. So as by way of background, the American Society of Clinical Oncology developed the model in front of us, the ASCO Patient-Centered Oncology Payment, which is a community-based oncology medical home model. And from here on out, we are going to refer to this as PCOP. This is noted to have taken more than 5 years of input from stakeholders, from oncologists, administrators, and payers. The stated goal of the PCOP proposal is designed to support community-based oncology medical homes featuring team-based care led by a hematologist and/or oncologist. The objectives of the 5-year multi-payer model are to transform cancer care delivery and reimbursement while promoting high-quality, well-coordinated, and high-value cancer care. The PCOP seeks to provide a comprehensive approach to delivering and paying for this high-quality cancer care. And I think it's probably worth noting that there's 2.3 million Medicare fee-for-service beneficiaries that are diagnosed with some form of cancer and seen by a hematologist or oncologist in the most recent data, which is from calendar year 17. And all of this is listed in your reference materials, which are available to the public. The Medicare total cost of care for these beneficiaries was $68 billion. It's noted that 82% of beneficiaries are treated by a single oncology practice, and there are 2,800 hematologist oncology practices in the United States, it is estimated, and 3/4 of those practices are considered, I think what we all would agree is small, and that's less than 6 providers. This proposed PCOP model seeks to be a life cycle-based cancer model that focuses on ensuring patient care, comprehensive oncology care through the application of specific care delivery requirements, safety standards, clinical care pathways, and the calculation of performance based both on quality and cost measures, with the structures designed to support a patient's cancer care, with time zero being at diagnosis and through treatment up to 1 year of active monitoring is the episode. The model's payment methodology seeks to support the required clinical practice transformation and provide incentives for value-based care, but also providing flexibility. This model, as written, has the potential to reach across borders, specifically small to large practices, urban, rural, and cross-state lines. The alternative payment model is described as practices providing the services of cancer care, specifically hematology and oncology-led, and specifically those who prescribe and manage chemotherapy and immunotherapies, which will become important as we go on. Multi-specialty practices with hematology oncology providers may also participate. The practices would serve as the alternative payment model entity for purposes of provider assignment, patient episode attribution, and performance measurement. Next slide, please. So core elements of the program, I am going to go through these in detail because, again, we've reviewed a number of models in the past, and some of these details may become important for us to deliberate. So I'd like to surface them now. First, the proposal calls for the creation of something called a PCOP community, and that is comprised of multiple providers, payers, and other stakeholders to facilitate implementation of the model in each geographic area. Participating practices would be required to comply with the 22 PCOP care delivery requirements, that are based on the oncology medical home standards and have an emphasis on the use of evidence-based treatment pathways. For those who may be interested in the reference material, there's a couple of articles in the peer-reviewed literature about pathway tools that currently are available and how they compare for your reference. The payment model includes a care management payment, a CMP. There's a performance incentive payment, a PIP, and the ability to receive bundled, what is being called as CPOC, not to be confused with PCOP, but the CPOC are consolidated payments for oncology care. The performance methodology is based on meeting quality metrics, adhering to pathways, and ultimately reducing care. The model includes 3 phases of cancer care: new patient, cancer treatment, and active monitoring. The model's care delivery requirements and the level of financial risk would differ between 2 tracks, a track 1 and a track 2. Track 1 practices would be encouraged to advance into track 2 within 2 years, and we'll talk a little bit about that going forward. Each PCOP community would need to be able to meet the requirements related to sharing electronic health record data from participating vendors via certified electronic health records, and there's some other data sharing requirements. Importantly, the PCOP model is designed with 2 tracks. Track 1 has no downside risk, but it's designed to encourage the participation of providers that may have less experience with alternative payment models and small practices who may lack the resources to engage in track 2. I would note that there is a year 0 in this model that allows for that infrastructure building. Both tracks require adherence to many of the same care delivery, safety, and clinical care pathways. And in our PRT report, there is a table available for you to see the differences between tracks 1 and track 2. But the main difference is that there are slightly different care delivery requirements. And then the bundle that I described previously of the consolidated payment is available because of the increased risk that is required in track 2. Next slide, please. This just is a visualization that shows the main components of the model. Next slide. So an overview of the proposal. The first is the role of the PCOP community. The expectation, or in the proposal, it's described as multi-payer, employer, hematology oncology practices, and other stakeholders in a geographic region that could represent a single metropolitan area, a state, or multiple states. And this would be led by an oncology steering committee. The Oncology Steering Committee is important because it makes many decisions about this model. It would select the high quality care pathways and a subset of 6 quality measures from ASCO's POCI program that are most relevant to the patient population for which it's managing. It identifies partners to facilitate successful implementation of the model, which include funding and project management. It potentially sets targets for pathway adherence rates, and we'll talk about that in a little bit going forward, and distributes performance metrics. It's also responsible for establishing the value of the CMP and PIP payments based on the PCOP guidelines. Although the proposal does not specifically define a minimum criteria for what a PCOP community participation is, the submitter has indicated that the 18 regions in the CPC Plus model, as well as some states that have the ability to leverage CERT technology, including existing health information exchanges or oncology-specific all-payer claims databases, would be most appropriate for this initial implementation due to the proposed model's data management requirements. The submitters also, during our discussions with them, indicated that while the model is designed to be multi-payer, it could be implemented as a single-payer program with Medicare. Next slide, please. With regards to the care delivery aspects, the proposed PCOP model builds on the oncology medical home model concept and features team-based care as previously described. Participating practices would be required to comply with the 22 care delivery requirements that are in 7 categories, including adherence to safety standards. And specifically in track 2, they would be subject to additional requirements that include patient and family advisory councils, triage and urgent care processes, in addition to utilization of pathways, patient navigation, risk stratification, and advanced care planning. And again, I'd refer you back to our report where it specifies all of those aspects, or to the submitter's proposal. Next slide. With regards to performance measurement, the proposed model focuses on providing incentives for value-based care that's further demonstrated in this performance methodology, which includes quality and cost performance metrics. It includes quality metrics and adherence to care pathways, and also cost of care metrics that are related to avoidable hospitalizations, emergency department use, and observation stays, and supportive and maintenance drug costs, which do include chemotherapeutic and biologic agents as previously described. This aggregated performance score, which is based on 1/3, 1/3, 1/3 of what I've just described, quality metrics, pathways, and cost, would be weighted to practice's performance. However, the submitter has indicated that the PCOP communities have flexibility to adjust weighting for other payers should the steering committee choose to do so. So with regards to these quality metrics, I've already previously described them. Adherence to pathways and cost of care we'll dive into here in just a few minutes. Next slide. With regards highlights of the payment model includes a 2-track design. Both tracks require data reporting on quality metrics, again, adherence to these pathways and care delivery requirements. But the main difference between track 1 and track 2 is that it employs a bundled payment that includes downside risk. Track 1 does not include that. Both tracks include a care management payment, a CMP, and a PIP, which is the performance incentive payments. And they will be calculated as a percentage of total cost of care. And they're adjusted based on where the patient is in their cancer care continuum, specifically those 3 categories of a new patient, cancer treatment, or active monitoring. Providers in track 1 practices would receive monthly care management payments that are worth 2% of the total cost of care, which includes all medical care fee-for-service payments, whereas providers in track 2 practices would receive 3% of total cost of care. We would note that the care management payments are not case mix or risk adjusted. Participating practices will also receive monthly performance incentive payments based on the performance and quality and cost measures and adherence to the pathways. For track 1, practices could earn up to 2% of the total cost of care, and performance incentives for track 2 are up to 3%. The clinical pathway adherence rates are included in the PIP calculation, and those are weighted by the proportion of treatments by cancer type. The cost measurements that are included in the PIP calculation are risk adjusted for cancer type. We described this in the report, that include things like secondary malignancy, bone marrow or stem cell transplant, clinical trial participation, etc. In track 1, practices will continue to receive fee-for-service reimbursements in addition to the case management payment and the potential performance incentive payment. In track 2, providers are required to participate in consolidated payment for oncology care, or again, the CPOC for short, and they may elect to bundle either 50% or 100% of the value of specified services and earn between a maximum of 90% and 104% of the previous fee-for-service amounts, depending on this aggregated performance score, which is made up of the 3 components of quality metrics, adherence to clinical pathways, and total cost of care. Next slide. So with regards to the payment model, the CPOC is the feature of the PCOP payment methodology that distinguishes it from the current oncology care model, or OCM, and has the potential for the greatest Medicare cost reductions. There's a lot of analysis, and this is actually where the Medicare Office of the Actuary was very helpful to us in trying to understand what that opportunity was for savings. And I'll refer you to our appendix of the landscape for that financial assessment. But briefly, the CPOC seeks to introduce financial risk for track 2 using this bundle that would be adjusted on a prospective basis based on performance, which would allow participating practices to know their expected revenue for the next period. The same performance methodology would be used to determine the CPOC that's also used to determine the incentive, or the PIP. Track 2 practices could face up to 10% downside risk and 4% upside, depending on what their aggregated performance score is. And the proposal states that practices that elect track 1 are expected to advance into track 2 within 2 years or be subject to discontinuation of the care management and incentive payments. However, the submitter indicated that participating payers would have discretion regarding whether to discontinue the CMP or PIP payments or to extend the deadline for transitioning based on business interests. Next slide. These are the 10 criteria that we were asked to provide review on as the PRT. These are our preliminary recommendations for us to review at this time. Next slide. These are the key issues identified by the PRT. There are several aspects of the model that warrant consideration as other care models are developed, such as the need for more local multi-payer efforts, greater payer participation, and a more balanced payment methodology that allows more practices, in particular small practices, to participate. A cancer model and the related care management payments that address the entire continuum of care rather than just the chemotherapy component, we thought was valuable, while holding participant practices accountable for only quality and cost, we thought was appealing. However, the model does not appear to meaningfully expand the portfolio of alternative payment models, in our opinion, that are available to hematologists and oncologists. The core aspects of the model are similar to the OCM model, which is our understanding. It is public that CNMI has an intention to extend that program through June of 2022. And that is currently going under potential revisions, and that there are several other oncology-related CMMI models. It is our understanding that are in development, including the Oncology Care First program. We noted that the proposal raised awareness for more local multi-payer efforts, as we described. However, there were concerns that requirements of this proposed model, including the performance and reporting complexities and the governance model of standing up one of these steering committees, and all of the requirements that were for decision-making that was held within this governing body was challenging, and it may limit the potential number of communities, payers, and practices that are actually able to participate. Next slide. While the PCOP model has the potential to improve quality and reduce cost, there may not be sufficient reductions in the total cost of care to achieve cost neutrality or net savings. I mentioned this before, but although the proposed model includes several features that encourage high-value care, the PRT was concerned that the recent evaluation of the CMMI OCM model indicated that care management payments are not resulting in statistically significant effects on Medicare expenditures or total cost of care, and these programs are older and more mature, and have not yet netted a significant savings to Medicare. I will note, and again, these are all in the appendices, but by way of background, a third evaluation of CMMI's OCM model found no statistically significant declines in total episode payments. In fact, the combined monthly enhanced oncology services and the performance-based payment for the 2 performance periods were greater than the small overall reduction that was noted. The proposed model also gives participating payers discretion related to applying the incentives that are designed to encourage practices to transition to track 2. As we mentioned, track 2 is where there is risk, and that's where there's an opportunity for savings. In the original proposal, it states that practices that elect track 1 are expected to advance into track 2 within 2 years or be subjected to the discontinuation of the CMPs and PIPs as I previously described. However, the submitter has indicated that if practices do not advance to track 2 within 2 years, participating payers in the PCOP model would have flexibility to decide to discontinue these payments or continue to extend the deadline. And so we had some concerns that ultimately, without this selection of track 2 or transition from track 1 to track 2 as a mandatory process, there's a potential that the cost savings would not occur and actually accrue costs. Next slide. Criterion 1, scope, which is high priority. Our conclusion was that this did not meet this criteria, and this was a unanimous conclusion. Briefly, the proposal seeks to provide a comprehensive approach to delivery and paying for cancer care, as I've described. The proposed model's use of geographically based multi-payer stakeholders, led by these steering committees and community-specific flexibility in selecting clinical pathways and metrics, could facilitate greater participation by private payers and smaller practices. The proposed model could provide an opportunity to test some alternative approaches related to value-based oncology care, including the life cycle continuum or episode that I previously described. But with regards to the proposal's potential to expand participation by medical hematologists and oncologists, including small practices, we thought it was important to note that currently approximately 5% of the nation's hematology and oncology practices participate in the CMMI OCM model. And those participating practices are noted to be relatively large. However, PCOP's 2-track model, track 1 is the model that would be most attractive to these practices who have limited experience, as opposed to track 2, which would require much more infrastructure and we assumed maturity. So that said, while the model could encourage the engagement of smaller practices, there may still be obstacles that could inhibit their adoption, such as the startup costs that are associated with establishing these PCOP communities. Again, employers, payers, providers, all working together. And also private payer adoption. That what I've noted before with regards to the steering committee being responsible for, lack of a better description, adjudicating performance. So the data analytics, governance, and ability to do assessments is quite rigorous and may be a barrier to entry for practices. And lastly, I'll mention that the model's data management requires also could be a barrier because there's either they have to be established or there's a commitment to developing, for instance, participation in a regional health information exchange or all payer claims databases. And thank you to Specialty Society who helped clarify to us that leveraging the 18 regions that are currently participating in CPC Plus may be the right target. Although we were a little confused because a large portion of the justification of the model was around practices who had no experience. And so we'll be interested to hear a little bit more about that. Next slide. For criterion 2, cost and quality, this is a high priority criteria. Our conclusion unanimously was that it did not meet this criterion. As mentioned before, the proposed PCOP model emphasizes quality improvement through practice transformation and allows some flexibility within the PCOP community as governed by the steering committee to address these issues. The oncology, the OMH concept and the model's care delivery requirements, adherence to safety pathways, safety standards and high quality care pathways have been shown to improve quality and safety and have the potential to reduce cost. And again, references to that are in the materials. However, there may be variation in the model's impact on quality across these various communities due to discretion and selection of these pathways and ultimately performance metrics, again, because those are picked within these community models or through these steering committees. There's a risk that any quality metrics that are achieved under the model may not correspond with significant reductions in the total cost of care. And again, we have other models that currently exist who have potentially informed that in order to achieve net savings or cost neutrality. And then I think it's also important to note that although the proposed PCOP model may not result in reductions in total cost of care or net savings, it would be helpful to address existing issues related to the quality of oncology care by improving adherence to pathways, improving and increasing consistency of care, coordination, and reducing variabilities and treatment. We absolutely agree that that's important. Next slide, please. With regards to criterion 3, which is payment methodology, and it's a high priority, our PRT concluded that the proposal did not meet this criterion, and this was unanimous. Again, briefly, the proposed model provides financial support for clinical practices through these CMPs. It includes financial incentive related to quality and cost. Track 2 seeks to increase the potential for cost savings by introducing financial risk and notable downside risk through the CPOCs using a bundle that will be adjusted prospectively. However, several of the proposed model's payment methodology features have the greatest potential to reduce cost are either optional or flexible and could be delayed, as I mentioned before. And drug costs, which are included in tracks 1 and 2, may be difficult to predict, which may make the proposed model challenging to implement and manage. The PCOP CMP amounts for new patients in cancer treatment are 2 or 3 times higher than payments for current E&M services, and they're also higher than the OCM's MEOS payment. And they would not be case adjusted. The submitter did provide data for us regarding the state of names model, which is estimated monthly CMP amounts for Medicare beneficiaries for new patients, which is currently $450 for track 1 and $675 for track 2. For cancer treatment, it was $225 for track 1 and $338 for track 2. And in their active monitoring phase, they provided us data describing the program as $75 for track 1 and $113 for track 2. The proposed PCOP CMP amounts for new patients in cancer treatment, as mentioned, are 2 or 3 times higher than the OCM's MEOS payment, which is actually $160 per month and is typically guaranteed for the entire 6 months. Finally, while part of the proposed model success is dependent upon multi-payer provider and stakeholder engagement, the PCOP's proposed community-led, multi-payer practice and stakeholder model, including employers, we thought may be difficult to implement in practice. Next slide. Criterion 4, volume over value. We unanimously voted that it does meet this criterion. I won't go through the details, but the quality metrics and adherence to pathways is one that's an improvement in the literature to decrease care variability and we believe improve value with regards to outcomes as a with use of pathways as a process measure. Next slide. Criterion 5, flexibility. The PRT concluded that this proposal met the criterion, and this was unanimous. If anything, you've heard us describe that we actually had concerns that there was too much flexibility, and that amount of flexibility may actually be problematic from an implementation perspective. Criterion 6, ability to evaluate. The PRT concluded here that the proposal did not meet this criterion, and this was a unanimous consideration. Again, the decentralization of this process into one that could be community-based. It was unclear how many of these communities may exist. Again, the suggestion was on during our inquiry phase that leveraging the CPC plus practices may be a viable option. But as written, there is no limit to the number of these communities that could be created. And therefore, we thought the analytics of such a program would be very difficult to evaluate the model. In addition to the data requirements and multi-payer aspects. Next slide. Criterion 7, integration and care coordination. The PRT conclusion was that the proposal met this criterion, and this was unanimous. I've already described a number of features related to this. Next slide. Patient choice, criterion 8, the PRT. Our conclusion was that the proposal met this criterion, and it was a unanimous conclusion. Given that patients were allowed to select providers within multiple of these communities, we felt that it met this metric. Criterion 9, patient safety. PRT conclusion was that the proposal met this criterion, and it was a unanimous conclusion. Next slide. Criterion 8, health information technology. The PRT conclusion was that the criterion was met. Just our assumption was that all of the access to each of these all-payer claims databases or registries or health information exchanges, if we assume that those are available, given what was described. And so that is a concern that we expressed through some of these other criterion. But with regards to the health information technology factors that we were asked to evaluate on, our PRT unanimously determined that criterion was met. And with that, I conclude my presentation.
Thank you, Jen. That was a nice detailed summary of a fairly complicated, not complicated in a negative way, but a fairly extensive proposal. So we appreciate that. And Paul, I wondered, you're on the PRT. Did you have any other additional comments that you wanted to make before we open it up to the committee?
No, I just wanted to thank Jen for a very comprehensive overview, as you said, of a somewhat complex, not to be, not in a negative way, but just complex model. And I also want to also add my recognition to SP staff and NORC for their help in understanding the context of this model within other models in oncology. So thank you, Jeff.
Thanks, Paul. And I think before we open it up to the committee, I just want to acknowledge Dr. Charles DeShazier, who was an excellent contributor to the PTAC and unfortunately had something come up that created his inability to continue on the PTAC, despite that would be what he wanted. So we just want to thank him and acknowledge him for his contribution while he did serve on the committee. So if you're out there listening, Charles, thank you. I'd like to just turn it over to the committee to ask clarifying questions of the PRT. Paul and Jen, any questions for them?
This is Bruce. I have one.
Bruce.
Jen, at the beginning of your presentation, you thanked, I believe you thanked the actuaries for their help in evaluating the proposal. And I didn't find that in the materials, and I apologize if it's there and I just missed it. But could you summarize for us in what way the actuaries helped you evaluate the proposal?
Happy to. I'll defer to staff to identify the location of their report. But their summary, and Paul, please chime in here, was that the description of the potential cost savings in the proposal was overstated. They cited previous models that were similar, but obviously not the same, and that's why we're here today. I would refer folks to a nice summary where there's a side-by-side of the PCOP model, the CMMI CPC Plus model, and the OCM model that's also available. But specifically with regards to cost reductions for emergency department observation inpatient care, they thought that the opportunity for savings in that space, based on their assessment of participation, was limited, and thought, as we've described here, ultimately that there would be it would be cost neutral, and actually their findings were that it would probably there would not be a cost reduction and actually add cost.
Thank you.
And this is ASPE staff. Just clarifying that in the ASCO PRT report on page 15, it indicates that the PRT sought additional information by communicating with staff in the CMS Office of the Actuary to gain a fuller understanding of the implications of the proposed model for Medicare program spending. In addition to that, as part of the overall environmental scan, our contractor NORC did some additional analyses, and then there are also some data analyses that were done, which also helped to support the findings of the PRT.
Thank you, Audrey. Any other questions from our committee to the PRT folks? I don't see any, but just wanted to make sure. All right.
Josh,
we're going to go ahead then and invite the submitters to participate.
Stop, Josh. Josh has a question. Josh has a question.
Oh, sorry. Go ahead.
Sorry about that, Jeff. I may have been on mute. Can you hear me now, everybody?
We can. Thanks, Josh.
Okay, great. Jen and Paul, thanks for the thoughtful, thorough review of the report. You know, my question is related to how PCOP thinks about quality. This may just be a clarification for me, but when I look at, I think, what is contained in section 6.1.3 in the proposal and 6.2.2, where they talk about the pathways and the quality metrics, it wasn't quite clear to me how quality would be measured, whether it be, for lack of better words, fit to a distribution, where there would be clear high and low performers. Certain parts of it seem to suggest that related to quartiles and percentile cutoffs. And then others note where if everybody's performing well, the OSC may go back and redefine that. And so it relates, I guess, to criterion 2 about this notion of being potentially able to increase quality. To what extent would that issue of kind of clumping of performance and quality versus a true distribution forced that way by the model did the PRT consider?
It's a good question. I'm going to answer it, and then I think this is one that we let the presenters, especially society and authors of the proposal, also opine on. But from the PRT perspective, and this is on a nice summary of our report, of our findings on page 7 of our report. Right, there's these 3 buckets: quality, pathways, and cost. One could argue that adherence to clinical pathways is quality, just to say it. So, right, there's 2 domains with regards to that. For quality metrics, they describe an opportunity for these communities, governed again by the steering committees, to select 6 quality measures. And then you're right, the methodology of adherence to benchmarks and performance setting is, as we understood it, to be a distributed governance model where these local communities get to decide how they want to evaluate that performance. And so there was not a standardized methodologic approach with regards to that, at least to a specificity that we thought that we could understand that would be standard. And again, that there was discussion around flexibility to be reactive through the 5 years, which actually it's 6 years for the first year, 0 year of performance. So the short answer is that methodology is not well described from our understanding. That we'll defer to the presenters coming up to give additional information about. Thank you.
Great, thanks.
Seeing no other questions, I think it would be good to go ahead and introduce the submitters. So while they're coming on, just a little housekeeping. I'd like Brian Bourbon will be the moderator for the team. So any questions that we have will be directed to him, and then he can direct them to his teammates. But I would ask the folks as they come on to please introduce themselves, and then Dr. Jeffrey Ward will be actually presenting the material. Thank you.
Right, can you hear me? My camera, the video feed from my camera seems to be having a little hard time loading. My picture may show up soon. Good afternoon, my name is Jeff Ward. I'm a practicing medical oncologist at the Swedish Cancer Institute. My site of practice is a community hospital and clinic north of Seattle. I've had the pleasure of 14 years of service on ASCO's Clinical Practice and Government Relations Committee, and with a lot of help, I founded and chaired ASCO's reimbursement work group for a number of years. Allow me to start today by thanking the preliminary review team and this committee for taking time to discuss the Patient-Centered Oncology Payment Model and to convey the importance of your work today. Medicare's oncology model, as you know, is nearing its end. It's expected to accrue its final episode in December of next year. And while CMS has laid out some conceptual design elements in the Oncology Care First RFI, they have yet to publish a finalized model. So we have an opportunity to shape what comes next. And unlike prior discussions that this committee has had regarding oncology models, today we have the additional benefit from the APT Associates evaluation of OCM's first 3 performance periods. So we have a clearer picture of what is working and what is hindering the goal of improving quality and reducing the cost of cancer care. We can consider those lessons learned as we discuss ASCO's Patient-Centered Oncology Payment Model, or PCOP as we refer to it. I'm joined today by Dr. Blaise Polite, Professor of Medicine at the University of Chicago. Dr. Polite and his colleagues were early adopters of clinical pathways and alternative payment models. His work has helped to shape ASCO's platform on the development and use of clinical pathways and their inclusion in the PCOP model. I'm also joined by Stephen Grubbs. Dr. Grubbs, in his role as Vice President of Clinical Affairs at ASCO, oversees the Distinguished Quality Oncology Project Initiative. It's a quality measurement and practice certification program, which has contributed many of the measures, including in the current quality payment program. And lastly, I'm joined by Brian Bourbon, Division Director of Practice Health Initiatives at ASCO. Prior to joining ASCO staff, Mr. Bourbon had firsthand experience in nearly a dozen alternative payment models and pathways programs. Together, we're available to answer any questions that this committee may have regarding PCOP. The nidus of this work was actually in 2012 at the request of the super committee tasked with finding a way out of sequestration. PCOP was first published in 2015 in the vanguard of physician-focused payment models. Since that time, we've benefited from shared experiences in multiple Medicare and private payer models. Recently, we submitted a assembled a multidisciplinary team from clinical practice, payer, and purchaser communities to update PCOP and prepare for submission to this community. In the few minutes that we have, I want to highlight a few features of the model. PCOP is first and foremost a care transformation model. It includes specific care delivery requirements for participating practices. These requirements are rooted in evidence and expert consensus to improve the quality and cost effectiveness of cancer care delivery. PCOP's performance and payment methodologies are designed to measure and incentivize the successful deployment of this new oncology medical home model of care. In designing the model, we were guided by two core principles. First, no provider should be financially penalized for providing the appropriate care to the appropriate patient at the appropriate time. And second, providers should be held accountable for aspects of care under their control, but not for aspects that are outside of their control. For all of its strengths, the oncology care model violates these principles. It essentially focuses on only one aspect of oncology care, the price of cancer drugs. The PCOP model, in contrast, focuses on the appropriate utilization of drugs rather than their price, and equally weights that with adherence to well-established and well-validated quality metrics and the costs of cancer care most directly under the control of an oncology practice, unplanned hospitalizations, ER visits and observation stays, and the supportive care drug costs. Paramount to these care delivery requirements is the inclusion of adherence to clinical pathways. For years, Medicare and Medicaid have struggled with the question of how to include oncologists in the effort to bend the cost curve of cancer care, when neither oncologists nor CMS actually set the price of those cancer care drugs. Clinical pathways offer us a solution by promoting use of treatment regimens that have been methodologically weighed by their efficacy, potential side effects, and the total cost of care. Adherence to these value-based pathways has been shown to reduce the overall cost of drug treatments while mitigating the risk of stinting on care. Further, if broadly applied, the incorporation of value into clinical pathways has the potential to exert downward pressure on some drug prices as competing therapeutics seek pathway inclusion. Finally, PCOP introduces a payment methodology which enables its goal of improving quality and reducing the cost of cancer care. It is easiest to describe PCOP's methodology in contrast to the current OCM. For example, if we recall, OCM establishes its monthly enhanced oncology services payments based on a 4% of calculated total cost of care. These payments of $160 per beneficiary per month were necessary for practices to put in place the enhanced services required under OCM. But this largest category of model payments failed to reflect the performance of practices who received them. Practices who wisely invested Mayo's payments into new systems of care waited nearly 2 years for additional performance-based payments, whereas practices who struggled in the model experienced no change in their reimbursement. PCOP's care management payments are similar to OCM's, but their base payment is calculated at 2% of the total cost, or 3% of practices in Track 2. The remainder is critically included in monthly performance incentive payments, variably based on the practice's ongoing performance in the model. This methodology rewards practices for achievement of improved quality, cost, and pathway adherence. Further, PCOP disrupts fee-for-service with consolidated payments for oncology care, taking a portion of current fee-for-service and moving it to monthly, partially capitated payments that are also variable based upon performance. PCOP enables the shift from a fee-for-service system that encourages increased utilization to a payment methodology that provides oncologists with the resources necessary for implementing innovative methods of care delivery, something that OCM has failed to do because of its myopic focus on drug prices. PCOP's balance of specificity and flexibility actually provides communities a model that allows for a true multi-payer participation and achievement of a common goal of a high-quality, cost-effective cancer program. We hope that our proposals and the answers given today will assist this committee in its review and recommendations of PCOP to the Secretary. We expect that you have many questions, perhaps clarifications we can answer. There were 3 specific issues broached by the PRT review that we would invite questions about specifically. First, the review expresses concern that the APT associates find that the OCM failed to generate overall savings from ED and hospital utilization during periods 1 to 3, and that this dooms any model that purports savings from utilization. Second, it questions why we believe that PCOP will attract and retain practices and payers where OCM or the model suggested by OCF-RFI cannot. And finally, we fear that we were not able to convey adequately to the PRT review team why eliminating the cost of drugs in a bundle and utilizing value-based pathways compliance to bend the cost curve is a radical departure from OCM, distinguish PCOP as a truly unique payment model. We would hope in particular to have a robust discussion on this latter topic. Thank you for listening. Please, any questions?
Great, thank you, Dr. Ward. And I'm now going to turn it over to the committee to ask questions for the proposal submitters. And please direct those questions to Brian Bourbon, and then he will allocate them out to his colleagues. Thank you. So I don't see someone queuing up. So maybe I'll ask the first question while we get seated here. HIEs, or information exchanges, is clearly one of the backbones of this model to accelerate its success. My experience with starting HIEs or existing HIEs, they're not ubiquitous. They're hard to get going. In California, we've been trying to stand up an HIE for the last 3 years, and so far have been unsuccessful in garnering the support to participate in fair data. All payer claims databases are great when they exist, but those too are also difficult to stand up. And so I would very much like to hear your input on sort of how you view that process unfolding, and from a timeline standpoint, how long do you think that will take? It would be great to hear your approach. Thank you.
Thank you, and this is Brian Bourbon, and I'll take that particular question. So as part of CPC and CPC Plus, and now Primary Care First, the idea of multiple payer, multi-practice data exchange is core to being able to evaluate cost across multiple payers and to be able to do so in a common format. We benefit in recent years from, there's actually an all-payer claims database council, which has a common data layout that they have provided states on the claim side. And so we feel, getting to a multi-payer model really requires that data interchange. We're now up to, in Oncology Care First, 26 regions that have dedicated to supporting multi-payer data and quality measurement for primary care. And we feel those regions are kind of primed to add oncology using the PCOP model. And so, yes, understand that there will be certain regions of the country who may not be as mature in being able to adopt a multi-payer model, but we hope that they would get there.
Thank you, Brian. I'm going to go ahead and turn it over to Grace for her question, please, and then Josh.
I've got several, so what I might do is just ask one or two, and then if there's more people that want to do it, I'll come back with the others, as opposed to dominating things. But one of the things, first of all, thank you all for your for presenting this and for proposing this. I think that oncology in general is one of the real miracles out there that we don't realize very much, that we've actually achieved a whole lot, at least over the course of my training. And when you actually look at survival rates and all that we've done, even within all the dysfunctions of our current healthcare system, the work that's been done in oncology is impressive. So from that point of view, I think one of the things that we need to be very careful with is that we don't break things with new payment models, even if we need them, as a result of somehow suppressing innovation. So I've got some background in genetics and genomics, and a professional certification in that. And as precision medicine is completely, potentially upending a lot of oncology in so many ways, my concern as it relates to this, or at least my question is, can the evidence-based medicine, the care guides, all the pathways that you all very consciously put in place. I noticed a lot of it was not related to, for example, DNA fingerprint, but still some organ or tissue sort of approaches to things. Can that keep up with the pace of innovation in the oncology field, such that we're going to continue to have all the success we've had, even if we're trying to measure things by evidence-based pathways? So that's my first question.
Yes, thank you for that question. Dr. Polite, would you like to discuss pathways and inclusion of emerging evidence?
Yeah, and thank you for that. And to me, that's why it is absolutely critical that you actually have pathways in the system. So if you look at the oncology care model right now, about 60 to 65% of episode costs are drugs. And if you look at the app report, essentially the reason why there wasn't savings, was Part D drug expenses. So if you're going to deal with oncology, you got to deal with drugs. The problem, of course, becomes our choice of what to give is so dependent on individual characteristics. The beauty of pathways, and there are several successful commercial pathway companies out there. We have implemented one here, Via Oncology, that came out of University of Pittsburgh, and several of our academic center colleagues across the country, all names you would very well recognize, are also on this. And these are committees that meet frequently, and the way the pathways are designed is actually you embed molecular component into it. So when I see a colon cancer patient, I check whether or not they have RAS mutations, whether they have microsatellite instability, and this then leads to pathway choices. So by having the pathways in there, you, number one, ensure that I'm actually practicing the most up-to-date evidence-based care based on molecular subtype, and is driving that quality change. So I think you actually improve quality. But the second thing is it allows us as an oncology community to adjudicate areas where we may have 2 or 3 competing drugs, or there may be a new drug that has perhaps small improvements that we don't feel is justified by the cost. So I think the pathways, I think, is the one place that really allows you to, one, make sure that care is not stinted, that 2, drive quality improvement by, requiring that people look at these molecular subtypes, and 3, allow us to deal with the major cost driver, which are drugs, in a way that does not result in any way hampering the innovation in care. I would suggest that if you design value-based pathways correctly, you actually encourage pharma and companies to look for higher value, meaning treatments that actually improve survival, improve quality of life to a greater degree, that will allow them to achieve, higher places, in a pathway that requires sort of forced choice.
Thank you. I'll let Josh do the next question. That was excellent. Thank you.
Thank you for the question.
Great. Well, thank you, Mr. Bourbon and Drs. Ward, Grubbs, and Polite for the presentation. I think, as was mentioned in the PRT report and as mentioned in your presentation, there are questions about kind of the potential for improving quality and containing costs. And I'm curious, if we take a big step back, I was struck by one of the responses to the PRT letter regarding OCM being, I believe, in the words of the letter, a cost-first model, and how PCOP is kind of a balanced model that focuses on cost and quality. Just so I'm not misunderstanding it, is it right to say that as PCOP is written now, it is a model that, in your estimation, will improve quality while simultaneously reducing costs? Does it kind of keep us cost or spending neutral while improving quality? Or the last permutation, perhaps, which is kind of maintaining quality and reducing costs? I don't think that's the one, but I'm curious how you guys would describe it.
Sure, thank you. I'll take that particular question. And so as the PRT shared, we have three categories in the performance methodology. We have cost of care, we have quality, and then we have adherence to pathways, which, as Dr. Flight mentioned, straddles and addresses both cost and ensuring high quality of care. And so a practice can succeed in the model and be above average if they hold costs equal but improve quality of care, or they hold quality equal and reduce cost of care. And so these categories are weighted equally for that reason, to encourage, striving on both those ends. Also, there was a question, and I don't know if the committee wants me to follow up on the question to the PRT, which was mentioned as a potential question for us regarding the scoring methodology.
Yeah, well, go ahead, Josh. Sorry, go ahead.
Yeah, go ahead.
Well, I also want to, I know Grace has a couple more questions as well, but yeah, why don't we go ahead, Brian, and answer that question, and then we'll get back to Grace. Thank you.
Sure. And so, so in the scoring methodology, both for clinical pathway adherence as well as quality metrics, we have designed quartile scores. And so in pathway adherence, if you're above the 75th percentile, that's 100% scoring on pathway adherence. And then in each quartile, that score goes down. In the quality measurements, we have, if you're above the 75th percentile, that's 100% score on quality metrics. If you're between 25th and 75th percentiles, then you're within a spectrum there of scores. And if you're below the 25th percentile, you're at 0%. Now, what we'd absolutely hope is that every practice is then well performing in each one of these areas. And some of the side effect of that is topped-out measures. And so then we leave it to the multi-payer stakeholders to address on how to handle topped-out measures, whether or not to continue with them and score everyone at 100%, or whether to drop that measure and select a new one. And that's just something, have to anticipate that as practices are striving for good performance, topped-out measures could happen.
And if I could just follow up on that, since I think I raised the question in my question to the PRT, I think that's helpful clarification. And it goes back to this question of my first one about quality versus cost, in the idea that you can imagine a situation where, outside of the extreme of being topped out, that the status quo may be that quality, as measured by a pathway or any set of metrics, may be high, low, in the middle. There may be lots of spread, very little spread. And so we could see situations where certain PCOP communities had quality performance that right out of the gate were very high, which may be excellent, but kind of begs the question of what is the quality improvement there versus the other side of it, where there may be a distribution of performance at the beginning. And so my question is really to understand kind of the flexibility and the design around that. So thank you.
Okay, thank you. Yeah, I think that's a great question. And so perhaps, Dr. Ward, can you talk maybe to the different tracks and how the tracks are put in place and options within PCOP to address where a practice is at entering the model? Dr. Ward?
He may have fallen off, Brian, for bandwidth issues.
Nope, I'm here. It had remuted me. We've kind of followed and tracked, I think, why practices have struggled with agreeing or staying in OCM. One of the struggles OCM's having right now is that there are very few practices that are willing to move to a two-sided risk model. We believe that the primary reason for that is actually the issue of including drug costs, something they can't control in a bundle, and that it's way too easy for your bundle to be broken by patient mix. We actually demonstrated that in some studies that we've done at ASCO, that your patient mix determines whether you're successful in OCM, not your choices. But the other, I think, factor certainly is just getting your toes in the water. And so we really believe that once a practice gets the infrastructure in place and is able to do so, that there are significant advantages and savings to both the practice and to payers in track 2. But that we need to be able to bring them into the fold and, in some degree, teach them how to do it. But the real key to the difference in the models and bringing people into it, I think, and what will attract people is the idea that they are not going to be responsible for something that they can't control. I'd refer you to a viewpoint, an opinion article that was in last week's JAMA Oncology, authored by some authors from Tennessee Oncology, a very large group that is in OCM and actually is one of the few groups that have decided to go ahead and take two-sided risk. And yet the whole opinion is that they shouldn't be in a position where they have to do that, and that the substitute should be pathway compliance as a way to control drug prices, instead of putting a patient's financial viability completely at the risk of a flip of a coin based on who walks in their door. I hope that answers the question.
Thank you, Jeff. Grace, do you want to ask your next question?
Sure, and I'm going to call it the 2 I's for integration and innovation. First of all, with respect to integration, not only with this oncology proposal, but with one that we had received earlier, there had been some not altogether positive comments from the public from other oncology types of organizations, such as radiation oncologists, who were basically saying that they felt that it was really important to have something that was not just restricted to medical oncologists as we were thinking about models of care. So that's the integration piece that seems to have been something that a lot of folks have objected to, although the specific problem you're solving for here is very specific to all the issues around chemotherapy. So I understand that piece of it. But having been the CEO of a multi-specialty medical group that had a oncology practice before OCM, trying to do some innovative stuff, there were some other types of innovations that were that we did, such as embedding psychology in the middle of the practice, using pharmacy in a different way, having a oncology-only urgent care where people with medical emergencies who were oncology patients could deal with things. So one of the things I'm asking in all of this is, does this model adequately address the 2 I's, the ability to integrate with the larger, to use the theme of this morning, medical neighborhood of other oncologists or surgical oncologists for that matter that need to be involved with the care? And number 2, is it going to allow other types of innovation besides just that related to therapy in a way that would be rewarded in the payment system here?
Yeah, Dr. Grubbs, would you like to mention some of our work with other oncology specialties and how they relate to this model, and then maybe I can address how shift from fee for service goes helps innovation.
Yeah, sure. Yeah, thanks, Dr. Terrell. Those are both important aspects of this model and a good question. The first one I'll tackle. If you read through the PCOP proposal, you're right, it is concentrating on getting medical oncology's house in order to be able to provide better quality care and also bend the cost curve. But it's set up where other specialties in the oncology space can join in. So I think our long-term vision is, yes, this would be attached to other types of alternative payment models that might work very well for radiation oncology and surgery and others. So I think the potential down the road is to bring together different specialties under one big tent in one alternative payment model. Having said that, I think there are issues that have to be worked out with our other specialists along the way that I know are working on right now, certainly in radiation oncology. So I think the potential there is to come together, and over the years, we've discussed these alternative payment models with our colleagues in other parts of the care team, because this is a multi-specialty treatment program. So yes, I do believe this is set up to be able to expand beyond our medical oncology part of it, but we'd certainly like to be able to feel that we have that worked out properly. So that's why this program really concentrates on that. And then the other question you asked, which I think is really an excellent one, is we're talking about drugs all the time, and we're talking about, did we pick the right treatment? Did the patient get the correct treatment? But that's not the entire care delivery system. It's just one piece of it. And this program is set up to be built on the concepts of an oncology medical home that will need to incorporate all those things you've just said to be sure that the care delivery for a patient and their family is optimal. And that includes having access to the care team around the clock, having access when you're ill immediately so you don't end up in the emergency room. And you have to build those systems within your practice. You need to have nurse navigation. You need to have support in areas other than just treating the cancer. So yes, this system is built on that type of model of an oncology medical home. There already is information out there on what the standards of that should be. And I have to tell you right now that we are in the process at ASCO working with the colleagues in the Community Oncology Alliance to actually update those standards, which I think you'll see published by the end of the year. So yes, that's part of that. And can I circle back, because I think you asked a really good question about pathways and you're concerned that it may actually slow down innovation of cancer care to patients as new things come out. I think Dr. Polite gave you the example of how quickly genomics are put into it. ASCO has actually looked at and defined what a high-quality cancer treatment pathway program system should look like and the types of things that need to be put into it. And one of them is rapid change in the pathway when new technology becomes available that's superior to the existing treatment. So in that regard, a pathway compliance gets the physician and the practice on track as new technology comes out in a short amount of time. And I have to unfortunately tell you, that's one of the problems we have across the entire country in oncology. When new technology comes out, the adoption of that sometimes is too slow. So compliance on a well-designed, rapidly changing pathway program solves that problem. And on the other side of it, by being compliant with the latest, newest treatment, it prevents stinting of care to patients too. So I think you get the best of both worlds. You get rapid change with new technology, and you also protect patients from stinting on care, because the physicians in this program will be measured on giving the right treatment at the right time, not having to pick between the cost of the drugs.
Grace, I want to circle back to the question you had about innovation. I love the fact that you had psycho-oncology in your practice. We have it in ours. It's a great addition to what we do. I remember, though, a number of years ago when we were pulling palliative care into our practice in the outpatient setting, I sat across from a CFO who said, I will not pay for palliative care when it's a program that's going to decrease my ER utilization without making any money. And in a fee-for-service world, it inhibits the ability to make that kind of innovation for that very reason. The things that you want to do that will decrease ER utilization and bring value to it are often things that are not paid for well in a fee-for-service world. That's why practices will move to a track 2. Because when you're in track 2, you have the ability to innovate. I can now say, okay, if I can actually help my practice by decreasing ER utilization, that gives me the opportunity to say a psycho-oncology program or a palliative care program or an urgent care after hours are all things that can help me achieve that I could not afford to do before, that I can do now because I can take that money out of a very expensive ER and put it into a lower cost program that will help change the cost curve.
I think I sit behind that same CFO. So anyway,
he's retired now. We've moved on.
And I was the palliative care provider with you.
Yeah. Thank you so much.
Is that, are you done with your questions? I've got one.
I'm done. Thank you.
Great. So the Oncology Steering Committee clearly is, as Jen mentioned, is an instrumental component of the proposal. They make a lot of decisions. They represent the stakeholders, and they are interwoven in pathway selection, quality, outcomes, et cetera, and really are driving the success of this proposal. Could you share a little bit more about how these steering committees and your approach to forming them, how they're governed, you know, what's their composition? I know you touched on a little bit in your proposal, but you know, the big tent, which I think Brian mentioned, I'd like to get a little greater insight into how you see that coming together. Thank you.
Sure. Brian, you want me to take that? I can talk a little bit about Washington State.
Yeah, you can talk about Washington State. I'll talk about Cincinnati. We've done it in primary care. I think we can do it in oncology. So go ahead, Dr. Ward. Thank you.
So in Washington State, you may be familiar with the work of HiCor, the Hutchinson Institute for Quality Outcomes, Cancer Outcomes Research. They've actually been kind of the go-between that has allowed us to develop a collaborative between a large number of practices in our state and the payers to begin to share both payer data and cancer program data to begin to look at things that bring value to our practice. That's developed a layer of trust and collaboration that we really think can be parlayed into being able to develop this kind of a network that could evolve into what you're describing. Certainly, it's going to require a collaboration and a degree of trust that we haven't had with payers before and that they haven't had with us. But I do think that the payers recognize that that is going to be necessary, and that building an infrastructure to develop their own sets of pathways to be able to shepherd us or herd us is something that'll be a lot more difficult than working with us. So I think that they are ready to come along and begin that collaboration. That's certainly what we've seen in our state. And we think that as providers, I think we're beginning to realize that we actually have a lot more in common with the payers in what our goals are for our patients than pharma has sometimes, and that we can work together to bend the cost curve in ways that we could never do apart.
Thank you, Dr. Ward. Yeah, so I would, mention that today the acting deputy administrator and director of Medicaid and the deputy administrator and director of CMMI release an informational letter to state Medicaid directors on how they can more get in the game of shift to value-based care. And they mentioned a couple of strategies that states should apply. One is multi-payer participation, that we need alignment of multiple payers in order to, achieve true value-based care and motivate providers to transform their care delivery systems. We need to adapt payment incentives and financial risk to the relative readiness of providers, especially for small practices and safety net providers. We need to promote advanced HIT, including the ability of providers to exchange data with their state. And importantly, stakeholder engagement. And that's multiple providers, that's multiple payers. The letter mentions patients, and as does PCOP. One party I didn't see in that letter, but is definitely in PCOP, are employers. As a provider, when activist employers say, we want you to move on quality initiatives, or we want to shift are networks of value-based care. Hospital systems definitely listen to that. And so, this is these PCOP communities are modeled after experience, for example, in Washington, or experience in my own town here in Cincinnati, where in primary care, we brought together multiple payers, multiple providers, the activist employers, patient advocates, our health board, and so on, to set priorities for our community, to discuss data, exchange and benchmarking local to the community. And I think that's where you really get a drive, high achievement of goals, rather than a fractured, system that we have today, where I may have one set of quality metrics with Medicare and OCM, but another with Aetna, UHC, and so on.
Thank you for that great answer. I don't see any other questions from the committee, but I'm giving one more last call, if you will. If there's someone with a question, this would be a great time to speak up. Hearing none, I too want to thank the presenters for attending today, but more importantly, for putting this proposal forward and working closely with the PRT and the ASPE staff to get us to this place. We appreciate, Brian, you and your team, Drs. Ward, Grubbs, and Polite. At this point, we're going to transition over to the public commenters. But again, thank you for your presentation and participating today.
Yeah. Thank you.
As we transition now, we have two folks who have signed on for public comments, the first of which is Harold Miller, former PTAC committee member. He is with the Center for Healthcare Quality and Payment Reform. Harold?
Hi, Jeff. Thank you. Can you hear me okay? I appreciate the opportunity to comment. I wanted to point out what I think are two unique and important aspects of this proposal that I don't think the committee has adequately recognized so far. One is that this model includes explicit protections against both undertreatment and disparities in care. All of the current CMS APMs include incentives to discourage overuse of treatment, but none of them have good methods of protecting patients against being undertreated. The CMS oncology care model gives physicians bonuses if they spend less on cancer treatment, but it has no mechanism for assuring that patients are receiving the most appropriate treatment. I want to emphasize that. The CMS model has no measures of appropriateness at all, none. In contrast, the ASCO model would be the first APM of any kind to tie payment to clinical pathways that specify what treatments are appropriate based on both effectiveness and cost. This, by definition, avoids both overtreatment and undertreatment. We should be particularly concerned about payment models that encourage undertreatment, given the substantial evidence about the racial and ethnic disparities that exist in cancer treatment. The ASCO model would actually help to reduce these disparities, since it requires that all patients receive appropriate care, and the reasons for any deviations from the recommended clinical pathways have to be documented, not hidden. The second unique aspect of this model is how it would reduce spending on drugs, which is an issue that's getting a lot of attention these days. Some of the differences, it differs in some substantial ways from OCM, and it's better than the oncology care model. Some of those ways have been discussed. I wanted to highlight two that really haven't been discussed. First, one of the problems with the oncology care model is it only counts Part B drugs in its measure of total cost, not Part D drugs. That creates a perverse incentive to use a more expensive Part D drug in place of a less expensive Part B drug. The use of the clinical pathways in the ASCO model actually ensures the most appropriate drug is used, whether it is oral or infused. Second, the ASCO model focuses separately and specifically on supportive drugs. If you don't work in oncology, you may have no idea how expensive some supportive drugs are. Neulasta, which is a white cell stimulating factor, is the number 6 drug on the Medicare Part B spending list. Medicare spent $1.4 billion on Neulasta in 2018, more than it spends on most types of chemotherapy. There are studies showing that 30% or more of the patients who get Neulasta don't need it, and that represents hundreds of millions of dollars in potential savings. And that's not the only highly expensive supportive drug that's overused. That is a major opportunity for savings, and it exists in both track 1 and track 2 of this model. The ASCO model not only focuses specifically on reducing unnecessary spending on supportive drugs, it also measures ED visit rates in order to ensure the patients aren't being undertreated in the process. I think the ASCO model is very different and superior to the CMS oncology model in many ways, but I think these unique components that I just highlighted are particularly important because they address some important national priorities right now, and they could also be used for APMs for patients with other kinds of conditions. So I would strongly urge that you recommend the ASCO model so that both oncology patients can benefit from this, and these kinds of techniques can be used in other areas too. Thank you.
Thank you, Harold. Sandy Marks from the AMA.
Thank you. And again, I'm Sandy Marks, and I'm making comments again on behalf of the American Medical Association. Congress created PTAC in 2015 in MACRA because of widespread concern about the lack of physician-focused alternative payment models in Medicare, particularly for specialists. Unfortunately, 5 years later, there has been little progress in filling that gap, as we also discussed this morning. Oncology, though, is a prime example. Every year, approximately 1 million senior citizens are diagnosed with cancer, and Medicare is spending about $70 billion a year for cancer treatment. But only 5% of oncology practices are participating in the oncology care model, and the evaluation results to date have been disappointing. The more than 2,700 other medical oncology practices across the country have no opportunity to participate in an APM that's designed for cancer care, and they would be unlikely to enroll or succeed in something like OCM. The Patient-Centered Oncology Payment Model developed by ASCO would fill this critical gap. Unlike the OCM, PCOP was designed by oncologists to enable them to improve the quality of care for patients as well as control Medicare spending. Because it specifically addresses the problems with both current payment systems and OCM, we expect oncology practices will participate in PCOP not just willingly, but enthusiastically. PCOP has many of the same strengths that led PTAC to unanimously recommend testing of the Mason oncology payment model last year. Moreover, the two models are complementary, not duplicative. PCOP could be implemented by many oncology practices across the country, and it could also help practices successfully transition to a model like the Mason model. Although it was appropriate for the PRT to identify the areas of uncertainty regarding PCOP's impacts on quality and cost and participation by other payers, these uncertainties exist in every payment model. And as with other proposals, the only way to definitively resolve them is to actually implement and evaluate PCOP. The AMA believes that the many strengths of PCOP far outweigh the concerns that the PRT identified, and that PCOP has significant potential benefits for both the Medicare program and for patients with cancer. We strongly urge PTAC to recommend its implementation. Thank you.
Thank you, Sandy. I'm going to ask the operator, those are the two folks who've signed up. Is there anyone on the line that has also raised their hand to provide a public comment?
No other comments.
All right, thank you. So that concludes the public comment section. I would turn to my colleagues on the committee. Are we ready to vote on the 10 criterion? All right, I'm getting some telepathic yeses here.
Yes.
So we're going to go ahead and open up our electronic application here and start the voting process. All right, let's go ahead and start. And we have, with Jay back, we're going to have nine folks voting on the proposals, on the criteria. So we're going to go ahead and start with number one, which is scope. The aim is to either directly address an issue in payment policy that broadens and expands the CMS APM portfolio, or include APM entities whose opportunities to participate in APMs have been limited. Please vote. Audrey, please.
0 members voted. 6 meets and deserves priority consideration. 1 member voted. 5 meets and deserves priority consideration. 0 members voted. 4 meets. 3 members voted. 3 meets. 5 members voted. 2 does not meet. 0 members voted. 1 does not meet. And 0 members voted. 0 not applicable. The votes roll down until a majority is met, which in this case is 5 votes. And so the majority has determined that the proposal does not meet criterion 1, scope.
Thank you, Audrey. Moving on to criterion 2, quality and cost, which is also high priority. Anticipated to improve healthcare quality at no additional cost, maintain healthcare quality while decreasing cost, or both improve healthcare quality and decrease cost. Please vote. Audrey, please.
0 members voted. 6 meets and deserves priority consideration. 1 member voted. 5 meets and deserves priority consideration. 0 members voted. 4 meets. 2 members voted. 3 meets. 6 members voted. 2 does not meet. 0 members voted. 1 does not meet. And 0 members voted. 0 not applicable. So the majority has determined that the proposal does not meet criterion 2.
Thank you, Audrey. Let's go to payment methodology criterion 3, which is high priority as well. Alternative payment model entities with a payment methodology designed to achieve the goals of the PFPM criteria, address in detail through this methodology how Medicare and other payers, if applicable, pay APM entities, how the payment methodology differs from the current payment methodologies, and why the physician-focused payment model cannot be tested under current payment methodologies. Please vote. Audrey?
0 members voted. 6 meets and deserves priority consideration. 1 member voted. 5 meets and deserves priority consideration. 0 members voted. 4 meets. 1 member voted. 3 meets. 7 members voted. 2 does not meet. 0 members voted. 1 does not meet. And 0 members voted 0, not applicable. So the majority has determined that the proposal does not meet criterion 3, payment methodology.
Thank you, Audrey. We're moving on to criterion 4, value over volume. Provide incentives to practitioners to deliver high-quality healthcare. Please vote. Go ahead, Audrey.
Okay, 0 members voted 6, meets and deserves priority consideration. 1 member voted 5, meets and deserves priority consideration. 3 members voted 4, meets. 5 members voted 3, meets. 0 members voted 2 or 1, does not meet, and 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 4.
Thank you, Audrey. We're going to move to flexibility. Criterion 5, provide the flexibility needed for practitioners to deliver high-quality healthcare. Audrey?
Zero members voted 6, meets and deserves priority consideration. 0 members voted 5, meets and deserves priority consideration. 6 members voted 4, meets. 3 members voted 3, meets. 0 members voted 2 or 1, does not meet. 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 5.
Thank you, Audrey. And criterion 6, ability to be evaluated. Have evaluable goals for quality of care, cost, and other goals of the PFPM. Please vote. Audrey?
0 committee members voted 6 or 5, meets and deserves priority consideration. 1 member voted 4, meets. 1 member voted 3, meets. 6 members voted 2, does not meet. 1 member voted 1, does not meet. 0 members voted not applicable. So the majority has determined that the proposal does not meet criterion 6.
Thank you, Audrey. Criterion 7, integration and care coordination. Encourage greater integration and care coordination among practitioners and across settings where multiple practitioners or settings are relevant to delivering care to the population treated under the PFPM. Please vote. Audrey?
0 members voted 6 or 5, meets and deserves priority consideration. 2 members voted 4, meets. 7 members voted 3, meets. 0 members voted 2 or 1, does not meet, and 0 members voted 0, not applicable. So the majority has determined that the proposal meets criterion 7.
Thank you, Audrey. We're going to move to patient choice criterion 8. Encourage greater attention to the health of the population served while also supporting the unique needs and preferences of individual patients. Please vote. Audrey?
0 members voted. 6 or 5 meets and deserves priority consideration. 6 members voted. 4 meets. 3 members voted. 3 meets. 0 members voted. 2 or 1 does not meet, and 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 8.
Thank you, Audrey. And criterion 9, patient safety. Aim to maintain or improve standards of patient safety. Please vote. Audrey?
0 members voted. 6 meets and deserves priority consideration. 3 members voted. 5 meets and deserves priority consideration. 5 members voted. 4 meets. 1 member voted. 3 meets. 0 members voted. 2 or 1 does not meet, and 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 9.
Thank you, Audrey. And the last criterion, criterion 10, health information technology. Encourage use of health information technology to inform care. Please vote. Audrey?
0 members voted. 6 or 5 meets and deserves priority consideration. 6 members voted. 4 meets. 3 members voted. 3 meets. 0 members voted. 2 or 1 does not meet. 0 members voted. 0 not applicable. So the majority has determined that the proposal meets criterion 10.
Thank you, Audrey. Do you want to just provide a summary of our voting for the 10 criteria, please?
The committee finds that the proposal meets 6 of the 10 criteria relating to criterion 4, value over volume, criterion 5, flexibility, criterion 7, integration and care coordination, criterion 8, patient choice, criterion 9, patient safety, and criterion 10, health information technology. The committee voted that the proposal does not meet the remaining 4 criteria, criterion 1, scope, criterion 2, quality and cost, criterion 3, payment methodology, and criterion 6, ability to be evaluated.
Thank you, Audrey. We are now, if there are any comments the committee wants to make before we move on to actually voting on the first cut of the recommendation to the secretary, which is not recommend implementation, recommend with subcategories, which will be the follow-on vote, and then referred for other attention by HHS. Are we ready to move forward? Looks like we are. So we're going to go ahead and vote. Audrey.
So 3 members voted to recommend, to not recommend the proposal. 2 members voted to recommend the proposal, and 4 members voted to refer the proposal. At this point, we need to have a super majority, which would be a 2/3 majority, which would be 6 votes. Right now, you don't have 6 votes in any bucket. And so I would ask the chair if the committee would like to talk some more.
Well, I think we do. And what I'd ask is I'll call on individuals and we can share how we voted individually and the reasons why, and potentially that information will help bring us to the point where we can re-vote. So I'm going to go ahead and call on Angelo first, and then I'll just work through the committee members, starting with you, Angelo. Thank you.
So thank you. Can you hear me?
Yes.
So, so I voted to not recommend, and I voted on that on the basis of that the 3 highest priority criteria we all voted, or the vote was majority does not meet criterion. And I felt that as we discussed it doesn't add to the portfolio that CMMI has today. And there were certainly cost issues and questions around the ability to evaluate this model. And so certainly did not meet the criteria to me to recommend. And I wasn't sure that referring it to attention by Health and Human Services was going to add any value to anything else that we might be considering. So.
Thank you, Angelo. Paul?
Yeah, thanks, Jeff. So I went with refer for other attention, but my reasoning was similar to Angelo's. I was going back and forth between 1 and 3, meaning should I do not recommend, but then highlight that I think there are some pieces of the model that I think CMMI and HHS should consider as they're thinking about oncology care models in general. So whether I put it in the not recommend or the refer, when I put in refer, it was really with the same message that I think there are some issues. Angela brought up several of them, which I agree with, and also this oncology steering committee challenges as well. That was my thinking. I could have either gone with, I would have had the same message, either going with not recommend or refer.
All right, Paul, thank you. Bruce?
I voted to not recommend, but I really am feeling pretty much along the same lines as Paul. I'm not comfortable with the not recommend choice, even though I think it's dictated by the results of the voting. But I'm very interested to hear more about what others think could be in a referral. And I agree that there are elements of the proposal. It's a serious proposal. It's got a lot in it. There may be elements that we would want CMS to pay attention to as they further develop their own portfolio of cancer models. So I'm interested to hear what others have to say.
Thank you, Bruce. Let's go ahead, Grace, please.
So I've been the outlier on all these votes that has been pressing the 5s and 4s, and I did vote to recommend. And really, it has to do with our new process, where if you vote to recommend, within the context of that, there are options out there that basically say to look at it within the context of another planned CMMI model, or to do it within the context of testing. So I believe many of the same things you all do with respect to there's complexity to it. It's hard to understand whether various aspects might work. But I actually think this is one of the most crucial issues that need to be solved for, which is how do you make sure that chemotherapy, which is so important as we take care of patients in this country, is neither stinted on nor a source of excessive profit and therefore overuse in a population that's vulnerable. And both are potentially things that can happen in our current fee-for-service payment system. So I thought that the focus on evidence-based medicine that was rapidly able to be sort of fixed in real time solved for a lot of that, and is something that CMS really, really ought to think about within the context of how it will continue to evolve its oncology care model after it, I guess, sunsets the current program in the end of 2022. I thought that Harold Miller's comments were true, that the current system does not necessarily focus on what to do about stenting, but the fee-for-service system, quite frankly, doesn't focus on what to do about excessive chemotherapy. So this was really focused on something that really crucially needs to be dealt with within our current healthcare system. And I thought they were very thoughtful with their answers to my questions as well as the rest of yours. So if we go down the path, as it looks like we're going to, refer, I want to be very clear from my point of view what that referral needs to be focused on, or the things in this model that I do think address and solve for some of the problems in the current oncology model. We heard in the Mason proposal previously similar things, that there were things that just weren't working. And we know that from some of the results coming out that we do see that there are things that CMMI is wanting to solve for. So if we're going down the referral route, I'm okay with that. But we need to make sure that it's very clear from the report that comes out that they are thoughtfully addressing one of the crucial issues in the payment system.
Thank you for those comments, Grace. Jennifer?
I think it's interesting because many of us, have voted differently, yet have similar reasons for our excitement about the proposal. My vote was aligned actually with Paul's in thinking that because our high priority, and then also Angelo, if we're not able to support high priority areas, I felt that I could not vote for one, but agree with Grace's comments completely that there are a number of features in this model that are interesting and attractive, and also agree that there is a concern that the current model or models that exist are not fulfilling the desire by the provider community to participate in a meaningful way, and they are identifying opportunities to do so. That's why my suggestion or my vote was for refer for attention. With regards to the points that I'll make now, there's three areas. One is what Harold described around the benefits of pathways. We had a similar discussion with the MESA protocol. And I'm excited to see that there's now peer-reviewed literature that are showing the value of adherence to care pathways, and also the thoughtful discussion the presenters and submitters made with regards to flexibility, because as we know, pathways are based on best evidence, then on consensus, and then on local resources. And so there has to be flexibility to continue to reevaluate them. The other point made around community that this proposal makes is around the value of community engagement in care delivery models, which I think has its own unique features in this submission, which I think it's important for us to note. And then finally, the comments about cost of drugs and why this model, I would not call it radically different, but when you look at the total spend, one might use the word radical, but the idea that there's an expansion of inclusion of drug costs, which obviously, again, because providers may not control some of that cost, they're still willing to take on the risk because they know their decisions around prescribing are within their purview. And so agree that the recognition of expansion of the definition of drug costs is one that is valuable and comprehensive. Thank you.
Thanks, Jane. Lauren?
I voted not recommend, but primarily rooted in not understanding fully what refer means. What I would ideally like to see is those unique elements that they identified around the flexibility in payment, the community-based collaboration, and the patient-centered approach and staging around how they've staged the risk, that they're actually partnering with CMS as they're redesigning that OCM model to integrate some of those unique elements. I thought Harold Miller's comments were really compelling, and ideally that's what I would like to see happen, but as a new member, I wasn't sure what refer actually means.
Thank you. Thank you, Lauren. We're going to have a discussion about that at the end of this. I go with Josh and then Jay.
Great. So I won't belabor the points. I think I share a number of the views that other committee members have expressed. I voted 3 refer for many of the same reasons. Just stepping through them, I did not vote 1 not recommend because I thought that the issues that this model, as I perceived it, tried to address were important. I think Grace said it well as well, that cancer care and chemotherapy are key, as evidenced by models that are being considered and focused on. So I thought there were issues to raise to HHS as that focus continues. As others have said, whether that's through kind of option 3 here or another means, I'm open to that. The reason I couldn't vote 2, I think others have echoed also, is that I thought around the high priority areas, there were fundamental ways in which this model was created, that it wasn't using another number, tweaking something here on a second or third order. There were fundamental ways that that limited this model as proposed. And I would say the connection here is that I think the key parts of the model actually, to me, don't necessarily address. They could, but they don't necessarily address actually the issues that others have mentioned, which I think should be referred as points for attention. So those for me are 3. 1, kind of engaging more oncologists across the spectrum and the patients they care for. 2, disparities. 3, stinting. I think these are key. I think we should signpost them. But I think that this model, as I understand it, doesn't fundamentally address those. So I voted 3.
Jay, you're up.
Well, I guess the beauty of going last is that everybody else voices your viewpoint at some point in time. So I'm a combination between Lauren and Grace. I didn't want to not recommend it, but not fully understanding refer, I went with recommend. I think there's some, really valid points to this model that are unique. I like the fact that it, really discounts cost because they don't control it, and trying to get, we've been in my past life and trying to get an oncologist engaged in this area for 25 years. So, anything that we can do to increase oncology engagement around, pathways, I'm in favor of, and that we need to push.
All right. Well, thanks, Jay. You're not the last. I'm gonna take up the rear here, but I voted to refer. And just for the newer committee members, I'll share with you my perspective on refer. Refer is not, and you've heard me say this at the committee before, where you sort of, the Raiders of the Lost Ark, the last scene where they're pushing, the Ark into that great vast warehouse. Refer is not sending it into a tar pit or a sinkhole. I would say, my feeling about this is this needs to be referred with high priority, as Grace has said. There are several elegant and important components within this proposal, not the least of which is evidence-based pathways and adhering to them, and having to explain in writing when you deviate from agreed upon care pathways that have been demonstrated to be successful. The clinical community, creating that clinical community of stakeholders, but also other critically important stakeholders, employers being one, who are often writing the checks and funding a lot of the oncology payments in this country. I think what intrigues me is those kinds of infrastructure accomplishments that would be necessary to drive this model, like the HIE data sharing, the all-payer claims database, establishing those communities. That infrastructure can then be used to power other proposals, other alternative payment models that will be introduced. It's been a conundrum for CMS and CMMI and for this committee, frankly, as we think about how to implement these models. But having that infrastructure actually built out and those tracks laid will be very, very helpful. And I think there's enough of a compelling argument that this model drives forward that would create the impetus to build that infrastructure. And I would hope that the Secretary and CMS and CMMI would pay particular attention to those elements. I appreciated Harold and Sandy's comments. Undertreatment is key and often, I won't say invisible, but it's very hard, it's very oblique, it's hard to discern when that's occurring. And I think that this model addresses that. So I firmly believe, I have high hopes for this model. And I think that referring it is anything but pushing it into obscurity, but actually putting it in a position where, and making a recommendation where CMS, CMMI, and the Secretary can actually take these components and build them out in an appropriate way to get a model in the field as the oncology care model sunsets here in the next year. So I hope that helps. If there's other comments now, having heard everybody share their perspectives before we revote, because we do need to revote. Are there any other comments from the committee members before we take on revoting?
I've got one, and I see other hands up. I don't know if they just put their hands down and or forgot to, or whether I'm jumping the gun, but I'll go ahead and jump the gun. And that is, I think what I just heard in this conversation was we got stuck in the original way that this high priority language was constructed from, the original stuff that came out of the Secretary's office, HHS, back in 2015. And that we've all said there are elements of this that are really must be considered and, part of what goes forward. But yet we would get stuck on the word recommend. Recommend seems to be something close to implement in our heads now. And if you don't have these high priorities, you can't recommend. I think some of that semantics, which is why we were all over the place with this. And after this conversation, I just let everybody know I'll go ahead and move it to refer, because I don't think I'm going to get a whole bunch of you to move it to recommend. But at some point, we need to think, maybe deliberate in public about what recommend means with respect to if it flunks a high priority, and whether that entire criteria needs to be broadened, so that it's either not recommend or recommend, where something that includes referral is part of that. At one point, for the newer members, we were talking about referral, something that came forward, and it was like, it really wasn't part of an alternative payment model. It was somebody had a clever idea for something in fee-for-service, or something like that. There was the not applicable category, which was, this isn't even in our, purview of what, we're responsible for under the statute. And then there was the refer, because it was something interesting, but not really what we were doing. So this is a broader conversation for later on, but I do think that what happened today with this particular one is an example that we need to think a little deeper about it going forward.
Thank you, Grace. I don't see hands up, but I just welcome committee members to please speak up if you have additional comments. Josh, Bruce?
Yeah, Josh, I'll go next maybe. I think echo again the sentiments around kind of the pieces are important. The way I put it together was that, you know, the key pillars of a model are important, and then the kind of the glue that hold it together, how it's pieced together really matters as well. I can look at pathways and say that is a clear, maybe for lack of a better word, innovation that we should put. But the question is, if we deploy in a way where every community can pick different ones, right? Then that's a part of how does it implement it that I think makes a big difference. We want to disrupt fee-for-service. I've heard that phrase mentioned a few times. But if there's no clear runway to track to, what does fee-for-service disruption look like in that way? So I think it's the way that these come together for me that's really important. And on the issue of disparity, since it was mentioned in public comment, I think many of us have mentioned it. I'll just highlight that in a model like this that oncologists in practice would sign up for, there are layers to this thing, right? As Jeff mentioned, it's oblique, it's hard to capture. Think about kind of the geographic representation. Not every place has HICOR, or like Washington State. And so where practices adopt this model, whatever benefits are there, if there are those benefits, people may be precluded from getting them in the first place. And then once you step through that level, the question is, do you get treatment, and whether that then is on pathway. So there's at least 2 or 3, 4 layers here that I think speak to this issue of, can we highlight the issues, but say how it's fashioned together really makes a difference. Just want to share that before we vote.
Thanks, Josh. Bruce, did you have a comment?
But my comment is, I think the people who have rationales for wanting to refer make very good points, and I'm ready to revote.
Okay, thank you, Bruce. Thank you, committee members. Azizel, let's go ahead and open it back up for revoting. Thank you. I think we're actually past this point, aren't we? Sorry, my screen glitched out. I'm sorry. Didn't mean to confuse you guys. Sorry. Has everybody voted? Because I only see 8. Oh, thank you. Henry.
So on the revote, all 9 members voted to refer the proposal for other attention by HHS.
Thank you, Audrey. I think this has been really helpful, and I think the next part of our meeting is critically important. A lot of us have already made comments, so I'm not asking for people to repeat them, but if there are areas of emphasis that we want the ASPE folks to hear and the public to hear that will be incorporated in the Secretary's letter, this would be a good time to share your point of view. If it's, I'll just go around and maybe start with myself. I think I was pretty clear that that I would like to see this referred on with a high priority because of the comments that I made earlier, everything from infrastructure establishment to care pathways and holding people accountable. And the fact that this is much more expansive for oncology care beyond the cost of drugs. Those are my points, and maybe I'll turn it over to you, Grace, and then I'll just run through the committee. Thanks.
But I think I've made my opinions pretty clear in the previous discussion, but I really like this new category that you invented of refer with high priority, Jeff, because it's not anything that we've used before, but I think that we should basically make sure that in our sentences that is bold-faced when we write to the secretary and say, we refer this with high priority for all the reasons that I and you and everybody else has already articulated.
Thank you, Grace. Jen, you want to go next?
The only other additional comment I would make, because we had so much conversation around pathways, is an innovation. This was surfaced by the submitters, and it didn't come up here, so I want to acknowledge it. And that's the idea that choosing to go off pathway should not be the path of least resistance. So documenting pathway not appropriate is something that would create some unintended consequences. The submitters described an intent to have a majority of patients on pathways, and that there are products in the marketplace where that is feasible. And then we have some data in the materials staff can refer to, around rates. Their expectation were rates of adherence could be 80 to 90%. And so I just want to acknowledge that. Thank you.
Thanks, Jen. Jade, you want to go next?
I don't have anything else to add, Jeff, than what I said earlier and the other comments.
Jade, you want to go next?
Did
okay.
No, what I said was I don't have anything else.
Thank you, Jay. Bruce, anything?
Nothing to add.
Yeah, I got that. And thanks, Jay. Bruce, go ahead. Nothing to add? All right. Lauren? Lauren?
The only thing I'd add is when they called out the 5% participation rate in OCM, I think this model sounds like it comes deeply from the medical oncologists themselves, which may increase participation if their ideas are incorporated.
Thanks, Lauren. Josh?
Yeah, I'll just be very brief to make one of the points I think we talked about, but from my perspective clear, which is that I would hope the referral with high priority identifies the issues that this proposal seeks to address. I think it's important to recognize kind of balance and what's the best way to get there. And it's not clear to me that the key coming together, the components of this put together, is the way to get around some of these issues. So I think as HHS was considered these issues, maybe starting from a broader level to think about all the options would be wise.
Thank you, Josh. Paul?
Yeah, only one thing to, I guess, be sure to emphasize, or at least to acknowledge the concept of the Oncology Steering Committee, although I think somewhat problematic in the proposal, I think is something, the sentiment of a multi-stakeholder group, I think is important for further exploration by CMMI, HHS, as I think identifying a role within a model would be of interest.
Thank you, Paul. Can folks hear me okay?
Breaking up a little bit.
You're just breaking up, but you're still there.
Okay, I'm gonna maybe I'm gonna have you take and just close this out.
What?
Actually, Jeff,
If Jeff can't do it, I see
Why
the,
do you guys keep on mute?
if he can't do it, I see the script in front of me, Audrey, and I can read it.
Right. Well, I actually also have one piece of unfinished business from the morning that I wanted to address. So whenever you're ready for that.
Right.
Go for it.
Go ahead, Audrey, and then we'll try and wrap this up. Thank you.
Sure. So
Go ahead, Audrey.
Sure. Relating to our deliberation on the ACP.
Go ahead.
Sorry, can you hear me? Relating to our deliberation on the ACP NCQA proposal in the morning, when we did the revote, we did not confirm the previous votes of a few of the committee members who had changed their votes. And so I wanted to just, for purposes of the completeness of the transcript, to confirm which of the committee members had changed their votes when we did the vote on the overall recommendation in the morning. And so in the morning, we had, the final vote was that we had one committee member who recommended further developing the proposal, and 7 who recommended testing the proposal as specified in PTAC comments. And so to the extent that you remember, if you changed your recommendation, could you provide that information? For example, there was one person who had originally recommended implementing the proposal as a payment model, and then they changed their vote. Do you recall who that person was?
Audrey, can you hear me?
Yes.
I believe I was the one outlier there in both instances.
Okay. So Jeff was the one who voted to recommend implementing as a payment model. Okay. There was one person who, one additional person during the first round who had voted to recommend further developing and implementing the proposal as a payment model as specified in PTAC comments. Originally, we had 2 in that category, and when we revoted, we only had 1 in that category. Is there anyone who...
That was me, Audrey. It's Bruce. I changed my vote from 2 to 3.
Okay, thank you. All right, and then we had one person that had originally voted in category 4, PTAC recommends implementing the proposal as part of an existing or planned CMMI model.
That's Grace.
That was Grace. Okay. All right. Thank you very much. That's very helpful, just for the sake of having a complete record for the transcript and for purposes of our voting documentation. So
Okay.
thank you very much.
Jeff, are you back up and running now? If you're not, I'm just going to take it from you here.
Well, if you can you see me and can you hear me?
No, I can see you sometimes, and your voice is still lagging a little.
Can you hear me?
I can hear you now, but then I did. All right, Angelo did not get a chance to actually add final comments. I'm getting
Go
that
ahead.
message.
Go ahead, Grace.
I already have, Jeff.
Thank you, Grace. So I don't really have anything to add. I think capturing all the comments and the discussion that resulted in the changes in votes was very thorough, and hopefully somebody captured all those comments. So thank you.
Okay, Jeff, there's still a lag, so I'm going to finish it out here, and just want to thank everyone for your attention at today's public meeting. It's not easy to do a all day long virtual meeting, particularly if you're Jeff, and San Francisco and having all sorts of issues out there right now. But anyway, we do want to encourage all of you here tomorrow for our first ever theme-based discussion. It's going to be centered around telehealth. If you're registered for the second day of the public meeting, you will receive the meeting WebEx link, password, and login information to join via email tomorrow morning, along with an overview, presentation, and a list of panelists for tomorrow's panel discussions. Registration for tomorrow will remain open through the meeting tomorrow, so please join us if you find you have time during the meeting. We look forward to welcoming previous PTAC proposal submitters and subject matter experts to learn more from the field about how telemedicine may impact alternative payment models. So tomorrow's half-day public meeting will begin at 7 a.m. Pacific time, 10 a.m. Eastern time, and the meeting is available via live stream at www.hhs.gov/live. And thank you very much and take care. The meeting is adjourned.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.